That's a good question. It very much depends on the age of the population that we look at. When we look at a traditional TAVI population, probably between about 15 and 20% of patients, unbeknownst to us, have bicuspid aortic valve disease. But of course, as we move down towards younger populations and lower risk populations, we're going to see that number grow to between about 50 and 60% of patients in their 70s, and probably to about 70% of people under the age of 65 with severe aortic stenosis have bicuspid aortic valve disease. This is the difficult one. There are a number of issues with TAVI valves that could limit their impact in the bicuspid space. But the pattern of calcification with the bicuspid is quite different to tricuspid aortic valve disease. There's asymmetry of the leaflets, calcium at the bases of those leaflets rather than at the tips of the leaflets that we see with tricuspid disease. And of course you have dilatation of the aortic root. Most importantly, in type 1 and type 2 bicuspids, we have calcified raphe, and those raphe can prevent the expansion of the valve and can either lead to significant degrees of paravalvular leak around the side of the valve, or indeed malexpansion of the valve itself, and thus cause problem with coaptation and the long-term durability of the leaflets. I think the important thing is a really good pre-procedural screening. The multi-slice CT scan is very important to try and understand what type of bicuspid it is, where is the calcium, what is the pattern of the calcification, and how severe that calcium is, and taking that information going to the cath lab. It's also important to size bicuspid aortic valves a little bit differently than we would with tricuspid aortic valves. Typically we would size a tricuspid valve by looking at the annulus, whereas when we look at the heavily calcified bicuspid, we size the valve a little bit higher, so we do something called supraannular sizing.